Thanks for staying around with us in this last boot camp. My name is Tessa Janovsky. I'm a PA from Arizona Liver Health. I'm going to talk to you today about, I went back. About the basics of MASH. So we're going to take a brief look at the updated nomenclature and differentiate MASLD and MASH among the spectrum of SLD, talk a little bit about the global prevalence and the epidemiological trends, recognize the significance of MASH and how it's a progressive disease. We'll talk a little bit about the roles of primary care and specialty providers in the evaluation of these patients, and then apply these concepts to a clinical case. So steatotic liver disease is the new nomenclature, this as of 2023, so not necessarily too new, but this was a global initiative kind of co-led by AASLD and EASL with the main reason for this was basically to analyze the shortcomings of NAFLD and NASH, basically the use of stigmatizing language and kind of the lack of really the true root cause of the disease. And so the overarching term of steatotic liver disease was chosen to classify individuals with hepatic steatosis due to a variety of etiologies. And so on the left, we have MASLD and MASH. We'll talk about MASLD in a second. We have alcohol-associated liver disease, or ALD. We have specific etiology, SLD, which will be drug-induced liver injury, or DILI, monogenetic diseases, which can be LALD or Wilson's disease, miscellaneous, which could be malnutrition, celiac disease, hepatitis C. On the very right, we have cryptogenic steatotic liver disease, which is basically hepatic steatosis without any other cause. MASLD and increased alcohol intake, or MET-ALD, is a new subtype within this umbrella of steatotic liver disease. And that's basically what it sounds like. It's patients with cardiometabolic risk factors and who have an increased alcohol intake. And this, in the clinical space, can be kind of a dynamic spectrum. You can have patients who are MET-ALD who are more MASLD predominant, maybe if they have more heavy metabolic burden, or they could fall more so on the right side if they intake more alcohol on the right side of the cut points. Looking at MASLD specifically, so in the presence of hepatic steatosis, the finding of any cardiometabolic risk factor would confer a diagnosis of MASLD if there are no other causes of hepatic steatosis. If there are any other causes, you can definitely have a combination etiology as well. They need to have at least one of the 5 cardiometabolic risk factors. For time purposes, I won't go too in-depth for those, but basically obesity, type 2 diabetes, high blood pressure, high cholesterol. And again, this excludes patients with alcohol consumption, basically greater than 1 drink per day for women and greater than 2 per day for men. How does this change affect my practice? It won't. So there's been several studies that show a near complete overlap between the historical NAFLD-defined populations and the MASLD-defined populations. This included results from studies based on natural history of the patient and also biomarker validation studies. And so basically all the recommendations in the AASLD practice guidelines on NAFLD can be applied to patients with MASLD and MASH. Fatty liver MASLD is the #1 or the most common liver disease worldwide, affecting about 25 to 30% of patients on average of the adult patient population. We see a higher incidence or prevalence in Latin America, in the Middle Eastern countries, and lowest in the African countries. North America, Western Europe, and Asia kind of all fall between 25 to 30%, depending on what study you're looking at. And this really does coincide with the rise in the obesity epidemic and also type 2 diabetes as well. So MASLD is more common in patients with type 2 diabetes, over 60%. I'll say that again, over 60% of patients with diabetes are going to have MASLD, and this prevalence has increased by 50% since the 1990s. So this really does show that MASLD is a major metabolic risk factor or metabolic complication of diabetes. We know that fatty liver MASLD is not just confined to the liver. There's a lot of common extrahepatic diseases that are associated with MASLD. Just talking about diabetes, with diabetes, it's really kind of a bidirectional relationship there. Patients with MASLD are more at risk for diabetes, and MASLD patients who have diabetes are at an increased risk of progression of disease. Other things like obstructed sleep apnea, chronic kidney disease has a higher prevalence in patients with MASLD, kind of independent of other risk factors. PCOS with that insulin resistance. Cardiovascular disease remains the biggest cause of morbidity and mortality with our patients, including coronary artery disease, strokes, those types of things. And there's also some studies that link MASLD with certain malignancies, stomach cancer, colon cancer. So this really highlights the need for a multidisciplinary approach with our patients. So looking at kind of how MASLD progresses. So MASLD starts with hepatic steatosis in the liver or simple steatosis. A subgroup of patients will progress to MASH, which causes inflammation in the liver and hepatocellular injury. Some of those patients will progress to fibrosis, and unfortunately, some of those will progress to cirrhosis and will be at risk for liver failure, need for liver transplant, and risk for HCC. We have a great HCC lecture coming up, but HCC we can also see in patients with fibrosis, not necessarily cirrhosis. And there's been studies of pooled analysis and liver biopsies that really show that the progression from MASLD and MASH is really quite dynamic. And as far as the time to progression, patients with MASLD will progress about 14 years per stage compared to patients with MASH is about 7 years. And 20% of patients with MASH will be what we call rapid progressors or fast progressors, which could progress to cirrhosis in a matter of 10 years. And so identification of those fast or rapid progressors is crucial and really is kind of an unmet need in our clinics. And there really isn't set characteristics quite yet, but we know that patients with higher ALT levels at onset or presence of diabetes, especially if it's been uncontrolled for various years, any family history, or even genetic susceptibility. There have been an increasingly number of what we call SNPs or single nucleotide polymorphisms that have been linked to MASLD. The most common one is going to be the PNPLA3 mutation, which causes just more triglyceride or fat buildup in the liver. And so environmental and other non-genetic factors can amplify the genetic risk that is conferred with these SNPs. So for example, central adiposity can heighten the risk of liver disease in patients who do have the PNPLA gene. And also there's a significant effect on concurrent alcohol use. So along with those cardiometabolic risk factors, as MASLD progresses to fibrosis and fibrosis worsens, we do see a change in the gut microbiome. It becomes less diverse. There's a higher number of streptococcus and kind of a shift towards gram-negative bacteria in the gut microbiome. And so together with the gut microbiome and metabolic risk factors, basically will just amplify the risk of progression in these patients who have genetic susceptibility. Go. Is it not going? It's going on the screen down here. Oh, okay. Oh, gosh. Sorry, guys. Okay, so not all patients with MASLD will progress to fibrosis, but we do know that there are certain subsets of patients who are at high risk for significant fibrosis. This is AASLD guidelines for the recommendation of screening in high-risk populations. So anybody with medically complicated obesity, meaning obesity with cardiometabolic risk factors, type 2 diabetes patients, patients with MASLD with moderate alcohol use, so our MET-ALD patients, and then any patient who has a first-degree relative of somebody with MASH cirrhosis. Okay, there we go. So overall, the key points to take away from the guidance is that MASH with F2 to F4 fibrosis is what we call at-risk MASH. These are the patients that we want to identify early because they have a higher risk of liver-related events and mortality. And the rates of progression differ among each patient, just depending on their baseline severity, individual environmental factors, genetic susceptibility. Cardiovascular disease and non-hepatic malignancies are the most common causes for mortality in patients without advanced fibrosis. However, in patients who have advanced liver disease, death from liver disease is predominant. So looking at management of these patients all start off in primary care, right? And so FIB4 is a great test, a great primary risk assessment test that can be done in the primary care setting. And the goal of this is to exclude advanced fibrosis in low-risk patients. FIB4 has a high negative predictive value, so it's not perfect, but if it is below 1.3, you can feel comfortable that they likely do not have advanced fibrosis. So calculating a FIB4, if it's less than 1.3, we can reassess depending on their metabolic risk factors every 1 to 2 years if they have diabetes, prediabetes, every 2 to 3 years if they do not. If the FIB4 is above 1.3, then that should prompt a secondary risk assessment using VCTE or the FibroScan to get the KPA or kilopascals or the ELF test. So if they fall in that low category, perfect, they can kind of go back to primary care and get reassessed. If they fall in the intermediate or high risk category, they should be sent to specialty care, either gastroenterology or hepatology. And our goal at that point is to identify these patients who have at-risk MASH, or unfortunately, if they do have cirrhosis. Also, if the FIB4 is greater than 2.67, that should automatically just, the patient should just be automatically sent to specialty care. Now, in specialty care, as far as management, once we receive a patient who has maybe at risk for indeterminate or high-risk fibrosis, there's a couple different things that we can do. We can order MREs. We can consider liver biopsy. We try not to do that unless we need to, but if you have indeterminate NITs or if there's any sort of uncertainty as far as other concomitant liver disease, you can think about it. Once we've accurately assessed this patient for fibrosis, if they do fall in the stage 0 to 1, we can reassess every 2 to 3 years while also having an in-depth conversation about lifestyle management, right? Proper diet, exercise, all that fun stuff. Stage 2 to 3, you can consider pharmacotherapy, especially in our stage 3 patients. Stage 2 as well, definitely consider pharmacotherapy. In those patients, we can reassess annually. If they're stage 4, then they would fall into that cirrhosis-based management with HCC screening and variceal surveillance. So let's look at a patient case. This is a patient that is all too common in our clinics. We have a 62-year-old female that was referred for elevation in her liver chemistries, ALT 62, AST 51, normal ALK phos, and T-bili. When you talk to her, you learn that she's had these intermittent elevations for 5 to 10 years. She's been diagnosed with fatty liver many years ago and was just told to lose weight. She has a past medical history of obesity with a BMI of 39, prediabetes, hypertension, hyperlipidemia, no known family history of liver disease, rare alcohol use. She works as a teacher. She's on lisinopril for her blood pressure and atorvastatin for her cholesterol. On exam, she does have central adiposity. So when we're doing a patient evaluation, so just kind of tag teaming with the daily conversation, we want to make sure that they're not on any medications that could possibly cause steatosis. This is more important as far as examples with our rheumatological patients, if they're on methotrexate or steroids, tamoxifen for patients with history of breast cancer. And then we want to make sure there's no other additional etiologies. So that's where our chronic liver disease workup comes in. We want to check viral hepatitis panel. We want to check for inherited liver disease, autoimmune hepatitis, autoimmune liver disease, and we also want to get some abdominal ultrasound imaging just for kind of general liver assessment. It's important to note when you're kind of analyzing these labs that it's common, probably about 20 to 30% of patients who have MASLD can have a reactive autoimmune antibody with a low titer, and that does not necessarily mean that they have autoimmune hepatitis. It's more just nonspecific in nature. We get that referral all too often of they'd be told that they have autoimmune hepatitis, but I come to find it's a positive smooth muscle with a 1 to 20 titer, and nothing else points to autoimmune hepatitis. So keep that in mind when you're kind of analyzing these labs. Ferritin also can be elevated in up to 50% of people, and that kind of shows just more of the systemic metabolic inflammation rather than true hereditary hemochromatosis. If their percent saturation is elevated, or if their ferritin is extremely elevated, typically over 1,000, then you can be more worried about hemochromatosis, and genetic paneling, genetic testing can be done at that time. In this patient, I would definitely check metabolic labs, see how her cholesterol is managed, see how what her hemoglobin A1C is. I also put a PEth on there. I think PEth is becoming more common in practice because the more you know, and patients often lie to us, right? So we want to have the most accurate information so we can really treat the patient. So back to our patient, her chronic liver disease workup was negative. Her PEth was negative. On her metabolic labs, you notice that her hemoglobin A1C is 6.7. So unfortunately, she has kind of transitioned into that diabetes group. On the ultrasound, she does have an increase in hepatic echogenicity, which is typical of hepatic steatosis, but the contour of her liver appears smooth and she has normal spleen size. So meaning that we are not concerned for any portal hypertension. So again, which patients still need a liver biopsy? If you have discordant results, we see this in patients. You're like Jeremy said, the VCTE may say one thing and the ELF says another, and so getting a biopsy will definitively kind of stage their fibrosis, or if you need to rule out any sort of concomitant liver disease. So going back to our patient, does she meet the criteria for MASLD? Yes, absolutely. She has hepatic steatosis on imaging, and she has 4 of the 5 metabolic risk factors. So what questions should we be asking pertaining to this patient? Does this patient have MASH? Elevation in your liver enzymes is kind of related to MASH, is kind of a diagnosis of exclusion. So once we have ruled out that there's nothing else going on, we can safely say that the mild elevation in her liver chemistries is likely from MASH, likely showing that steatosis may be causing some inflammation in her liver. Does this patient have any fibrosis? And more importantly, does this patient have advanced fibrosis? So accurate fibrosing staging is key for these patients because that will guide your management. What steps can be taken to optimize her metabolic health? As mentioned, her hemoglobin A1C was high, kind of taking her into that diabetes diagnosis. So I would definitely be discussing ways to kind of optimize that. I would talk to her about GLP-1s. We can kind of target both things, get her diabetes under control, and now that it is approved for MASH, we can try to get that as well. So overall, kind of in conclusion to all of this, MASLD and MASH is the updated terms are MASLD and MASH, and they emphasize kind of the central role of metabolic dysfunction in the liver disease process. It's extremely common, especially in patients with obesity and type 2 diabetes. And most patients won't progress, but those with MASLD and fibrosis are at highest risk for poor outcomes. Cardiovascular disease remains the leading cause of death in patients with MASLD and MASH, and there is a high percentage or high prevalence of extrahepatic diseases, which basically underscores the need for multidisciplinary management in these patients. So ultimately, our job is to recognize high-risk patients early, make recommendations, and manage their metabolic risk factors. And overall, the goal is to prevent both liver-related and extrahepatic complications. Thank you.